I think you also touched on what key selection criteria we have for TACE and for TARE. We mentioned functional reserve of the patient, their child Pew class, their ECOG performance status are all very important. And I think this really takes us to the BCLC criteria for staging our liver cancer patients. And so when we treat, we want to make sure that we're not treating patients that are otherwise candidates for curative therapies. We would want to use either resection if the patient is a surgical candidate, or if they're unresectable and an ablation candidate, ablation would be favored, as those are our curative therapies. And then if our patient is not a candidate for these curative therapies, see if they're a candidate for transplant. And we can use TACE and TARE to bridge a patient to transplant. We would use TACE if a patient is not a Y90 candidate. Y90 or TARE has improved durability compared to TACE and improved efficacy in recent trials. And we'll touch on some of those trials in some more detail here later in our talk. But we want to make sure that we have adequate functional reserve, that there's no extrahepatic disease. We don't want to be treating patients that have extrahepatic disease with local therapies. That's really the realm of systemic therapies. And then if we can get a patient to an imminent resection, or they're going to be transplanted in short order, TACE and TARE are going to have similar benefits. If the patient is going to be on the waiting list for a while, we've got evidence that TARE is going to be a better option.
That's great. And you highlighted a lot of things, including, what the goals of the treatment are, how we're selecting the patients, what's the best therapy, for those patients, and who we really want to receive this therapy. Just briefly, you had discussed the trials and disease-free survival and overall survival, and just some any key points that we've taken that we should be able to take home from some of the trials that have been done using TACE and TARE.
Sure. I'll start by highlighting that I think that this is a very heterogeneous disease state. And when we look at intermediate stage HCC, we have disease biology that's indolent, and we have disease biology that is very aggressive. And at the time that we're making these decisions, oftentimes we don't know what the disease biology is. And we don't traditionally biopsy these patients, particularly if they're going to be transplant candidates, because there's risk of tract seeding, and we don't want any chance of disease outside the liver if this patient is a potential transplant candidate. And so I think we have to take these trials with a grain of salt. But looking at those original TACE trials, Lieu and Lovett, showed that there was significantly improved overall survival with TACE. One of these trials was done with doxorubicin, the other was done with cisplatin. And from the Lovett trial at 2 years, they found overall survival of 63% versus 27% in best supportive care arm. And we're not going to get best supportive care comparative trials at this point because we have so many other options for these patients. But this data gives us an idea of what TACE is actually doing. Riyad Salem out of Northwestern did the premier trial. Was a randomized controlled trial of conventional TACE versus radioembolization, and showed that progression-free survival in the TACE group was 7 months, and that's in line with historical data. Northwestern is one of the country's best radioembolization centers, so I will highlight that they do great work with Y90, but in their hands, Y90 had greater than 26 months progression-free survival in the premier randomized trial. So The median PFS was not met. It was greater than 26 months. I think one of the best trials I've seen recently was a randomized trial out of Belgium, published in Radiology in 2022, looking at BCLC-B hepatocellular carcinoma in unresectable patients, and compared DEB-TACE with Y90, and found time to progression in the of 17 versus 9 months, Y90 versus DEB-TACE. So Y90 had about twice the progression-free survival. And then overall survival was 30 months in the Y90 group versus 16 months in the DEB-TACE group. So my takeaway from this trial is, first off, my personal preference is to do Y90 if I can, because it works well in my hands. But I think that the other takeaway here is that if we're going to do TACE, we need to be thinking about how we're doing it, and maybe do it differently than we have in the past. Consider these pressure-enabled therapies, balloon TACE. Make sure that we're doing it in a selective fashion. Limit non-target deposition of our chemoembolic. And I think we have to look at different techniques when we're doing TACE, unless the patient is not a Y90 candidate.
Yeah, that's absolutely incredible information, and really neat to see some of that more recent clinical trial data come out. And thank you for talking about that, as even some of those trials I was not even aware of. So that's great, Dr. Lindquist.